Well, welcome everyone to Advances and Breakthroughs in Urology Andrology. Today's presentation will be given by Dr. Peter Tsambarlis. Peter Tsambarlis is a distinguished urologist. He's known for his expertise in men's health and his dedication to patient care. He did his fellowship with Wayne Hellstrom at Tulane University and previously worked at Rush Medical Center before joining Northwestern this year in 2024. His areas of expertise and specialization include management of Peyronie's disease, medically and surgically, erectile dysfunction, as well as prostate cancer survivorship. He serves as the committee chair of the Medical Students and Residents Committee for the Sexual Medicine Society of North America, and he's dedicated to delivering high-quality urological care to our patients, as well as furthering advancements in our field. So please welcome Peter Tsambarlis, who will talk to us about the non-surgical treatment options for Peyronie's disease. Take it away.
First, Dr. Bennett, thank you for the kind introduction, and I'm really gracious for the opportunity to speak on a topic of which I am passionate. Fair warning, it does get a little data dense early, especially when we discuss the oral therapies, but it does transition into a more conversational style as we get to the more practical things and things behind which we have more evidence. I am going to try and target approximately 45 minutes so that we have a little time for discussion at the end. I have no disclosures relevant to this talk or otherwise. So starting with a little background on Peyronie's disease, we do accredit it to François Gigot de la Peyronie. However, this was probably described about 500 years earlier by Guglielmo de Saliceto. We agree now that the pathology is started off by an event which is thought to be microtrauma, whether it be recognized or not, resulting in an exuberant scar formation and ultimately an associated permanent deformity in the erect state. So this inelastic scar is particularly critical to the pathophysiology of Peyronie's disease. We are very confident that this is highly underreported. There are prevalence rates up to 22% in autopsy studies. When I'm counseling my patients, I estimate approximately an 11% rate, but the variability in these prevalence rates is quite significant. It's important that patients understand that spontaneous resolution is very rare. And for the purpose of this talk, the goal of non-surgical therapy is to offer treatment which makes scientific sense and can either halt progression or improve penile deformity. The challenges in evaluating the Peyronie's disease literature are many, but the ones that I find the most troublesome are the various endpoints and the definition of success. So different studies have utilized different endpoints, including plaque size, degree of curvature, pain, percent of responders, and IIEF scores. On top of that, they have defined success by a number of different definitions, including functional straightness, curvature under 30 degrees. Are those different? Are those the same? Is it simply the patient's ability to participate in penetrative intercourse or restoring that ability? Is an improvement greater than 5 degrees significant? How about 20% improvement relative to their starting curvature? And many studies utilize statistical significance. And the question of whether statistical and clinical significance are the same is certainly in question here. There are studies showing as little as a 4-degree difference that have reached statistical significance. So for the sake of this talk, I am utilizing curvature primarily because I believe that's the most objective endpoint and the best one. However, when there is encouraging data on some of these other metrics like plaque size, pain, percent of responders, I do want to report that literature as well, because oftentimes those studies are the ones that justify the use of these agents. On top of all of these metrics, there are variations in patient selection, measurement techniques, and treatment decisions that are kind of present throughout the Peyronie's disease literature, and particularly so in the non-surgical space. So again, circling back, the goals of non-surgical therapy is to provide a regimen which makes scientific sense, is safe, and can either halt progression or improve penile deformity. I'd like to go through all the different types of non-surgical therapy one by one, starting with the oral therapies, then moving on to topical, radiation therapy. We'll spend a significant amount of time on intralesional therapies, mechanical therapies, and then end with combination therapy. So starting with oral therapies, the advantages of oral therapy are simple to understand. They're easy to administer. Physicians are very comfortable prescribing oral therapies. They tend to be inexpensive, and the side effect profiles are relatively limited. The downsides are questionable efficacy, which we're going to review in detail, and the question of whether or not target tissue levels are achieved via this route. I want to start with vitamin E because as recently as 10 years ago, this was the most commonly prescribed agent for Peyronie's disease, and it's still relatively common. The mechanism of action is that vitamin E is an antioxidant, and theoretically, the reduction in oxygen-free radicals could reduce collagen deposition in the tunica albuginea. The support for the use of vitamin E primarily comes from a single trial. This was a trial of vitamin E used as part of a combination therapy. In the study, 70 patients were divided between two groups. The treatment group was vitamin E plus verapamil, blueberries, propolis, and topical diclofenac. And the control group was that same regimen without vitamin E, so verapamil, blueberries, propolis, and topical diclofenac. And in this study, they found a 12.25 degree improvement in the vitamin E group and a 6.73 degree improvement without vitamin E. They also showed improvements in plaque size and IIEF scores. And what we're going to see is that this is a common theme amongst the oral therapies, is that inclusion of an agent in a combination regimen yielded slightly better results. So the support for vitamin E comes not as monotherapy, but as part of a combination regimen. However, when we hold vitamin E up to the stringency of a randomized control trial, we saw several small trials which did not show benefit, and then one larger trial which was aimed to definitively answer this question. In that study, 236 men were randomized to either vitamin E, carnitine, combination therapy, or placebo, and there was reduction in curvatures in all four groups, but notably, nothing outperformed placebo. And thus, as monotherapy, it's very unlikely that vitamin E produces any sort of response. This is going to be what you hear over and over again in the oral therapy space. So moving on to carnitine, the mechanism of action is very similar between carnitine and vitamin E. It's an antioxidant mechanism and reduces oxidative stress. The support, again, comes from a small trial of 48 patients, which notably did not have a control group, but found a statistically significant improvement in carnitine over tamoxifen therapy. And in that study, that was a 7-degree improvement. However, in the previously discussed study, where 236 men were randomized to one of those four groups, carnitine was one of the groups and did not outperform placebo. So again, no oral therapy outperforming placebo. L-arginine is used primarily as a global vasodilator. It's a stimulator of nitric oxide synthase, increasing nitric oxide production and diminishing collagen synthesis. This actually has been demonstrated in Peyronie's plaques in vitro. Of note, there are no randomized controlled trials in humans using L-arginine. However, there are case reports showing positive results, again, in combination therapy. The one I'd like to highlight is 74 men treated with either intralesional verapamil, L-arginine, and pentoxifylline, and the variable in this study was the use of traction therapy, which we'll discuss in more detail. But the group with traction improved 26.9 degrees, and the group without traction improved 20.9 degrees. These are both significant improvements and speak to the possibility of including L-arginine in the combination regimen, but it has not been evaluated as monotherapy. Pentoxifylline is similar. It is a non-specific PDE inhibitor, which blocks TGF-beta. TGF-beta is known to be elevated in Peyronie's disease and is actually utilized in some rat models to produce a Peyronie's model. This would prevent deposition of collagen. And in vitro, the results are quite encouraging. Pentoxifylline was found to inhibit fibroblast proliferation, reduce collagen deposition and elastogenesis. It decreased TNF-alpha secretion, which is another marker that we know is elevated in Peyronie's disease, and also decreased fibrogenic growth factors, the previously noted TGF-beta, but also connective tissue growth factor in a rat model. However, when we look at the human studies, there have been 3 studies of pentoxifylline. The first showed calcium content of plaques stabilized in pentoxifylline as compared to vitamin E, which we know did not outperform placebo. The second is that pentoxifylline was included in the study of verapamil with or without traction which established the possibility that L-arginine was useful. However, the most notable support for pentoxifylline comes from a single study where it was tested as monotherapy, where patients had a significant improvement in penile curvature if they were treated with pentoxifylline versus a dramatic worsening in patients in the control group. But it's very important to note that the strongest support of the use of pentoxifylline comes from an article that was ultimately retracted. And since that information is not always readily available, we tend to perpetuate the use of these agents based on historical data without keeping track of the rare instances of retractions like this one. Some of the lesser used agents that I want to focus on include POTABA. POTABA is theorized to increase MAO, monoamine oxidase, and inhibit fibroblasts. There was a randomized controlled trial evaluating this, and POTABA did not outperform placebo. There was a decrease in plaque size, but no significant change in penile deformity. Colchicine is a potent anti-inflammatory, traditionally used to treat gout and particularly acute flares. It is meant to inhibit collagen synthesis and decrease levels of inflammatory mediators. The evidence comes from a pilot study which showed improvement in 7 of 19 patients treated with colchicine, and a follow-up study, which was larger, 60 patients treated with colchicine during the acute phase, showed a similar 30% improvement. Neither of these studies had a placebo arm. They showed a similar response rate of about 30%, but objective data was not available. So we're basically using a patient report to measure success with this agent. Tamoxifen is a non-steroidal estrogen receptor antagonist, which diminishes fibrosis via, again, a decrease in TGF-beta, which we do agree is an important chemical mediator in Peyronie's disease. The evidence comes from a retrospective review of 31 patients. 11 had improvements in penile deformity on tamoxifen, so again, that roughly 1/3 or 30% response rate. However, this prompted a subsequent randomized control trial of 25 patients randomized to either tamoxifen or placebo, and again, no objective improvements in curvature were noted. This moves us on to the PDE5 inhibitors. We are all very familiar with PDE5 inhibitors and their mechanism. They increase levels of nitric oxide by inhibiting degradation of cyclic GMP to GMP, which decreases fibrotic activity. It is important to note that PDE5 inhibitors are safe for the treatment of ED in men with PD. So, of course, you can treat your Peyronie's patients with erectile dysfunction utilizing PDE5 inhibitors. However, the question of whether or not they can reduce penile curvature is less clear. In the most fundamental way, multiple studies have been a little bit discouraging. The first was 39 patients randomized to sildenafil or vitamin E, and they showed a 9-degree improvement in both groups. Now, considering the data on vitamin E and its inability to outperform placebo, I would consider this essentially no response. A follow-up study, or a separate study of 100 patients, which was partially meant to evaluate shockwave, did evaluate shockwave with the inclusion of tadalafil versus shockwave without tadalafil. And in that study, penile deformity was completely unchanged in both groups. So again, it is unlikely that PDE5 inhibitors alone are going to reduce penile curvature in your Peyronie's patients. However, there is some in vitro work that would suggest that maybe this meets the criteria of making scientific sense. PDE5 inhibitors did halt or reverse Peyronie's-like plaques in a rat model, and there was also a similar anti-fibrotic effect seen in a cavernous neurotomy model, which is meant to simulate a post-prostatectomy state. And I will go into detail as to why I included that during this Peyronie's talk. In humans, septal scarring was reduced or resolved in about 2/3 of men receiving daily tadalafil, compared with only 10% of men in the placebo group. We know that the Peyronie's plaque is anchored at the septum, whether that be dorsally or ventrally. So a reduction in septal scarring would suggest maybe we can have some sort of modification of the disease process, whether that be halting progression or even prevention. So while evidence of curve reduction in humans is lacking, I think the plausibility of this antifibrotic effect justifies its use as part of a combination regimen. But more research was done on specific populations. For example, the active phase. In one study evaluating whether daily tadalafil or low-dose sildenafil given daily to men in the active phase would have an impact on their Peyronie's disease, it showed curve progression in the PDE5 inhibitor group of 0.87 degrees versus 5.72 in the control group. This was not statistically significant, but the idea being that if we can reduce the amount that the curve worsens, maybe we're making significant clinical progress. Moreover, in this study, the duration of pain was less in the PDE5 inhibitor group. So patients who took daily PDE5 inhibitors had pain for approximately 9 months versus the control group, which was 12. So there might be a role in pain reduction, but again, the curvature data here did not meet statistical significance. The last thing I wanted to discuss for PDE5 inhibitors is prevention. So as I mentioned, they have utilized a rat model, a cavernous neurotomy model, to simulate the post-prostatectomy state, and it did seem encouraging. And what we've seen is this may be true in humans as well. So it's noteworthy that historical data shows a 15.9% Peyronie's disease rate after prostatectomy. But one study utilizing tadalafil, again, as part of a combination regimen, not as monotherapy, showed Peyronie's disease only developed in 2.9% of the patients in this study. And this was a large study of 581 patients. So while historical data does not represent a control group, this is a significant difference of having a 3% Peyronie's rate versus 16%. And perhaps there is something to this in terms of preventing that exuberant scar formation or that inelastic scar formation that characterizes Peyronie's disease. So in short, counsel your patients that oral monotherapies are not going to reduce their curve. There's very poor data for most of the agents. A few I've highlighted I think can reasonably be included in a combination regimen. That's L-arginine, pentoxifylline, and PDE5 inhibitors. And of course, PDE5 inhibitors can be utilized to treat ED in a Peyronie's patient. I'd like to move on to topical therapies. The advantages of topical therapies are simple. You can deliver the agent directly to the site of interest. In general, you avoid systemic side effects, and application is considered easy. On the downside, you can have local reactions to the skin, and there's a questionable tissue penetration, which has been evaluated. The most important agent that I want to highlight is verapamil. Verapamil is a calcium antagonist, which decreases the incorporation of proline in the extracellular matrix, and thus could be a target for hypertrophic wound healing disorders. The evidence comes primarily as part of a combination study with 57 patients randomized to verapamil gel, trifluopyrazine, or magnesium sulfate. And after 3 months, all of these men were treated with topical verapamil for 6 months, and 94.4% reported improvements in curve. There were no objective measures given in this study. However, in the tissue penetration data, there was a study of 8 men who were already scheduled to undergo surgery for Peyronie's disease, and they enrolled in this prospective study of topical verapamil. They applied topical verapamil the night before and the morning of surgery, and then at the time of surgery, a small specimen of tunica was taken and sent for the presence of verapamil. In this study, no verapamil was detected in any of the tunical specimens. So it's unlikely that any significant tissue penetration is occurring with verapamil gel that could potentially have a therapeutic benefit. This led to EDMA. EMDA is gaining a little bit of steam in the intravesical space. Is that by applying a small current through the drug mixture placed directly over the plaque, you can increase the tissue penetration to areas which were previously unavailable through topical administration alone. Because verapamil was the first topical, it's the one that's been studied most extensively. So I wanted to highlight 3 studies, which overall were somewhat discouraging. The first was 49 patients treated with verapamil and dexamethasone versus placebo, which showed no improvements in penile deviation. A second study compared EMDA delivered verapamil to saline, and the groups were equivalent, thus verapamil was not superior to saline. And the third group was comparing EMDA or intralesional verapamil, and again, no significant decreases in deformity were found. This technique is not readily available and seldom used, but I think historically significant, and especially with its recent gain in popularity in the intravesical space. I only briefly want to touch upon radiation therapy for Peyronie's disease. Radiation is easy to deliver and can have a profound anti-inflammatory effect, but it should be noted there's a significant risk to nearby structures, and in the case of Peyronie's disease, side effect on local erectile tissue. Radiation therapy does induce nitric oxide synthase and can exhibit very strong anti-inflammatory properties. There was a lot of data on it, and thus one review evaluated it due to the lack of a standardized definition of success. And that review actually concluded that low-dose radiation can be effective in the early stages of PD. However, that same review noted that potential side effects of radiation on erectile tissue outweigh what they identified as the limited benefit. So radiation therapy cannot be recommended at this time, and it's not going to be in the future. Now I'd like to slow down because there's a lot stronger evidence in these next three areas that we can actually make a significant change in penile deformity using these non-surgical interventions. Intralesional therapies are the first one. The advantage is that this drug can be applied directly into the plaque. So unlike relying upon the absorption properties of a topical, you can place the agent directly into the impacted area. In general, you do avoid systemic side effects, and amongst the intralesional therapies, we do have an FDA-approved option. On the downside, they are more invasive to the patient and more labor-intensive to the provider. The currently available, the FDA-approved injectables are quite expensive, and patients are accepting a risk of increased local side effects like bruising, pain, and tunical rupture. It is important to note that, again, for the covered agents, they are not recommended for calcified plaques, ventral plaques, or severe curves. However, I will present some data that suggests that perhaps these special populations are likely to benefit similarly or maybe even more than the more traditional counterparts. And anytime you're doing invasive therapies, expectations need to be made very clear. As you get more and more invasive, I think patient expectations increase. And you need to understand that these are all meant at curve reduction, but unlikely resolution. The first agent was actually introduced in 1954, and that's corticosteroids. They are thought to reduce progression via a potent anti-inflammatory effect. The encouraging evidence came from a retrospective study of 45 patients. These were patients in the acute phase, and there was a curvature decrease in 20.5%. A separate study of 112 men treated with betamethasone, hyaluronidase, and lidocaine reported cure in 31% and improvement in 55%. But in this study, no objective measurements were reported. So the AUA has made a clear stance on this due to the substantial systemic and local side effects. Corticosteroids are not recommended in the treatment of PD. Moving on to the agents that do carry an AUA recommendation, we have a return of verapamil. Verapamil, as we previously discussed, ultimately increases collagenase activity through the pathway of reducing the incorporation of proline in the extracellular matrix. There are several studies on intralesional verapamil, and the initial experience was encouraging, which prompted a larger study of 46 men, 54% of whom had objective improvements after 12 injections. However, these prompted some randomized controlled trials, the first one being a small 14-patient study, which only showed those encouraging results with regard to pain and narrowing, but not in penile curvature. And then another follow-up of 80 patients randomized to verapamil or saline injection did not note a difference in penile curvature. So despite that, some of that early data has prompted the AUA to include verapamil as an option, especially as a low-cost option for patients who aren't going to be able to obtain approval for things like collagenase, which we'll discuss in a second. Interferon alpha-2b was the other historical injectable. It works via decreasing fibroblast proliferation. The studies on interferon alpha-2b were of very high quality, and thus it does carry a higher grade than the verapamil recommendation. The first study was 117 patients randomized to either interferon alpha-2b or saline. And what they showed was a 13.5 degree improvement in the treatment group versus a 4.5 degree improvement in the control group. Now, of note, the 4.5 degree improvement was statistically significant improvement, as was the 13.5 degrees, obviously. So this study prompted the first discussion of, is there a therapeutic benefit to needling the plaque? So the traumatic rupture of plaque, independent of the agent used, may have benefit. However, this 9-degree improvement of interferon alpha 2B over the saline would suggest that this is probably a meaningful change. And it's important to note that this 9-degree improvement was replicated in subsequent studies. However, we do have to discuss the possibility of clinical significance versus statistical significance. So I don't think many providers would consider a 4.5-degree improvement clinically significant, despite the fact that it met the statistical criteria. This moves us on to Clostridium collagenase histolyticum. The trade name is Xiaflex, commonly abbreviated CCH. This was approved by the FDA a little over 10 years ago in December of 2013. The rationale is that collagenase is capable of directly breaking down PD plaque. The evidence comes from multiple studies, primarily the IMPRESS 1 and 2 trials, which were randomized controlled trials that consistently showed approximately 17-degree reduction in absolute curvature. The IMPRESS trial protocol is listed here. This is a total of 8 injections given out in 4 sets of 2. Each set of injections starts with an injection on day 1, a wait period of 1 to 3 days, followed by a second injection, then 1 to 3 days again, a healthcare provider modeling, and then approximately 6 weeks of modeling at home. This whole protocol takes approximately 6 months. Some of the excluded patients were the ones that I noted at the beginning, patients with ventral curves, calcified plaques, or severe curves over 90 degrees. Ventral curves in particular have been looked at, and particularly in one retrospective review of 228 men, they benefited at least as much as their dorsal counterparts. So in this study, 25 of the 228 men had ventral curves and actually improved by 29.5 degrees as compared to 15 degrees in the dorsal curves. There was no significant increase in serious adverse events. Another special population that is not mentioned anywhere on the package insert for Xiaflex is the acute phase. Traditionally, we have reserved invasive therapies for the stable phase. However, the possibility of halting progression and early intervention has made the acute phase a particularly promising area. In one study, 36 men out of 162 were in the acute phase, and the acute phase in that study was defined by pain and a duration of less than 12 months, which I think in a retrospective study is a reasonable way to define it. And the acute phase patients had a 16.7 degree improvement compared to 15.6 in their stable phase counterparts. Now, despite those numbers being really similar, I always take extra time to counsel my acute phase patients. And the reason for that is if I can obtain a 10-degree improvement in curvature in an acute phase patient, I cannot be sure if that is equivalent to 10 degrees in the stable phase, or if I have prevented some degree of progression that could have actually worsened the patient. So it's not that they are worse candidates, but rather that I want to say that I have a lessened ability to predict the outcome in the acute phase than I do in the stable. But I am still enthusiastic about utilizing it, especially in my motivated patients who understand that they are not surgical candidates during this more dynamic time. I'd like to go over how I give Xiaflex. And the reason is because I've seen some patients come in who had been receiving intracorporal Xiaflex. I saw a study from last year that approximately 40% of urologists treating Peyronie's disease are not inducing an erection prior to offering injection therapy or surgery. And I think that the way to maximize the utility of this tool, which is really all that Xiaflex is, it's a tool for us in the treatment of Peyronie's disease, is to follow a protocol that you can reliably reproduce and that has some data behind it. So in the first injection of every cycle, I inject a vasoactive agent and ensure a rigid erection. I measure and document the curve every time, and using a skin marker, mark the point of maximal curvature on the patient's skin. I do inject in the erect state, and I'll discuss this in the future, by having my assistant place the penis on full stretch, and then I instill local anesthetic into the plaque. I'm left-handed, so you see my non-dominant hand forming a backboard or giving me some counter-traction on the right side. That is to allow the needle to pass through this rigid plaque that does tend to kind of push away from the tip. Once I have that resistance and that scratchy sensation at the tip of the needle, I force the lidocaine through the plaque such that I should have a dent on my thumb if it goes properly. Once I'm happy with that pathway, I replicate it with the CCH and use the fan or trident technique popularized by Dr. Mills to spread that medication out throughout the plaque. I instill the full volume and push through that resistance. When I'm done, I wrap the penis in a gauze and a Coban from distal to proximal. You can wrap the distal much more tightly than the proximal to prevent postoperative swelling, and if at all possible, I ask patients to maintain that for 24 hours. These are the three most important points of the technique, in my opinion. The first is to mark that point of maximal curvature, and you will ultimately favor injecting at the POMC over where the burden of the plaque is. In terms of injection, you want to use that second hand so that that plaque is stabilized, and when you place that needle through it, you can feel that resistance and then push through it using force from your thumb. And then finally, a picture of the dressing in place, again, tight at the distal, looser at the proximal, and I put it all the way up to the corona. The most exciting data that came out of the AUA this year in men's health, in my opinion, was on Peyronie's disease and the utility of XIAFLEX in a more optimal way. Dr. Trost suggested some, what he called simple modifications to the IMPRESS protocol with some pretty astonishing results. He injects on back-to-back days, so never this 1 to 3 day wait period, but rather on the next day, always injecting in the erect state, favoring the point of maximal curvature over the plaque, and aggressive modeling. And I would strongly agree that the first 3 of these are simple modifications. However, I would always caution somebody when they're incorporating aggressive modeling into their practice. I do it, and I think that it has some profound effects, but you are certainly accepting more hematomas, more bruising when you incorporate this aggressive modeling. So do it slowly and only to your degree of comfort. But in terms of curvature improvement, the effect was pretty profound. Dr. Trost put the new modifications in 2020, and what he saw was utilizing the most recent data, meaning patients who were mid-cycle were included. There was a 50% improvement in the response amongst people who use these simple modifications, so from 20 degrees to 30. Not surprisingly, if you take out people who had not yet completed their treatment or hadn't declared themselves satisfied, you get an even better response. So that same 20 degrees previously, but another 3.8 degrees in patients who had completed the protocol. Another way of looking at this, and the way that I found most encouraging, was what percent are achieving different milestones. So in the IMPRESS trials, we defined success as a 20% improvement. And using the most recent definition, that jump went from 61.6%, approximately 2/3, what we kind of expected out of the IMPRESS trial, up to almost 80%. And then the even more impressive aspect of this is who are the patients who are having these really profound improvements, these greater than 50% improvements in their curvature. And that actually doubled. And then not surprisingly, if you take out the people who are actively going through the protocol, you get even better results. So amongst people who completed all 8 cycles or were satisfied, you have almost a 94% success rate. And when you look at the cost benefit analysis of XIAFLEX, which is an expensive agent, and how it compares to other therapies, increasing the response rate makes it a much more useful tool. And then likewise, these major responders, these greater than 50% responders, went up from only 23% up to 60.4% of patients. And I think this is largely driven by the aggressive modeling, but I have put all of these modifications into my practice, and I've seen similar results, so I certainly believe in it. Moving on to the more experimental things and the things that I get asked about in clinic, I do want to mention stem cells. Stem cells are a hot topic. They're difficult to study. They tend to be politically charged, but we do see some encouraging data in animal models. for Peyronie's disease, a rat model was created by injecting TGF-beta into the tunica albuginea, and then the stem cells were injected 24 hours later. In that study, fibrosis was presented. These rats did not develop Peyronie's disease. There are no studies in the model of the chronic phase. There are no studies in humans. And due to the challenges associated with studying stem cells, I don't expect them anytime soon. One of the two most common agents that I get asked about in clinic is PRP, platelet-rich plasma. And this is primarily in the erectile dysfunction space, but it is certainly making its way into Peyronie's as a potential intralesional therapy. I think there was one really strong review done on PRP, and that was done in 2022. Ultimately, they showed some support for pain reduction, some change in plaque characteristics, which were present in both the control groups and the PRP groups. But in general, studies that showed favorable response in the measured metrics lacked control groups and were of lower quality. So the authors, I think, put it extremely well. So I want to quote them directly. There is no solid scientific evidence that PRP might be effective in the treatment of ED and PD. And at the AUA 2 years ago, it was just described as not ready for prime time. And I think that statement still stands. So in summary, the intralesional therapies do have options for monotherapy, and you can utilize interferon alpha, verapamil, or collagenase as a monotherapy, or all of them could be used as part of a combination regimen. Do not use corticosteroids and do not use PRP for Peyronie's disease at this time. The last potential monotherapy I want to discuss is mechanical therapies. The benefits of mechanical therapy are that we can apply traction and countertraction forces to the penis and expect change. This is the same mechanotransduction mechanism that we utilized in braces in teenagers, or that some of the babies use when their skulls are misshapen after birth. They do not rely on pharmacokinetics to deliver drug to the target, and there is no risk of systemic side effects. However, they can be uncomfortable, and successful therapies typically require a significant time commitment, and thus compliance can be very challenging. The other agent that I get asked about almost daily, in addition to PRP, is shockwave therapy. In Peyronie's disease, shockwave therapy is meant to directly damage the plaque and increase angiogenesis around the plaque, leading to inflammation and plaque breakdown. The one positive study for the use of shockwave therapy in PD is 100 patients randomized to shockwave or sham, which showed a 2-degree improvement in the treatment group and a 2-degree worsening in the sham group, which was statistically significant. However, because of how popular shockwave is, there was a separate meta-analysis done of 17 treatment groups, which showed no difference in curve between shockwave and sham, and thus it is not recommended for the treatment of penile curvature. However, because it's so popular, last year, another updated recommendation came out on the use of shockwave in Peyronie's disease, which showed, yes, a reduction in plaque size and pain, but no change in sexual function and no change in curvature. And this more updated study I felt was very powerful because all of the studies that they included were using focal shockwave therapy. And focal shockwave therapy is the one that has shown encouraging data in the erectile dysfunction space. It does have the potential to penetrate down into the tissue that is relevant. And thus, if there was a benefit, it would probably be with focal shockwaves rather than radial. The ones that are advertised on the radio are typically radial shockwaves, and the likelihood that they can penetrate beyond the skin and provide any therapeutic benefit is extremely low. So I always caution patients to stay away from those types of therapies. The first traction therapy was actually vacuum, and this relies upon the reorganization of disordered collagen and active remodeling. The encouraging data came from 31 patients who applied a vacuum pump for 10 minutes twice a day for 12 weeks, and 2/3 had a 5 to 25 degree improvement, with 3 worsening and 7 remaining unchanged. The problem with vacuum therapy to me is that it does not meet the criteria of making scientific sense. I don't see how a mechanotransduction force can be effective with such a short period of time. Logistically speaking, my Peyronie's patients tend to be unable to use vacuum therapy because the deformity in the erect state and the restriction associated with that hollow plastic tube kind of prevent those two things from working together. So as the penis gets more erect, they can't fit it in the tube, and then they can't maintain it in a position where any benefit could occur. Traditional traction therapy, however, with a stretching device, does make more sense to me. It works via an increase in collagenase activity, leading to tissue remodeling, and was extrapolated from Dupuytren's contractures, which are very responsive to traction therapy. A couple retrospective studies showed improvement in curve. First one was 10 patients getting a 17-degree reduction in curve over the course of 6 months with an associated increase in length. A follow-up study requiring 5 hours a day for 6 months had a smaller response, 4-degree reduction in curve, but it should be noted that this study had a starting curvature of 31 degrees, which would be considered a relatively low, especially mean starting curvature. Ultimately, a review of 55 patients with PD in the acute phase was done and compared traction to no intervention at all, and curvature decreased 20 degrees in the traction group with improved sexual function and improved pain. The traction data was then built upon further by the addition of the RestorX device, which is a second-generation traction device. This reduced the daily requirement from 5, 6, or 8 hours a day down to 30 to 60 minutes. And the primary difference is the ability to apply that force in a specific direction. So in the top picture in the middle here, we have a patient who had a dorsal curve, stretching it ventrally, and then the bottom would be a patient with a rightward curve in the erect state, stretching to the left. They also introduced this novel clamp device for glandular support, which seems to be well tolerated. In terms of curve reduction, 110 men randomized to either traction therapy or no therapy, all with curves 30 degrees or greater for 30 to 90 minutes per day. They found curve reduction in the traction group compared to a 1.3 degree increase in the control group, and the men in the traction group gained length. There were limited adverse events. Of note, 100% of the men in this study who had some experience with other traction devices as well preferred the RestorX device, so that might be an endorsement of this new clamp. The authors actually extended this study to include 6 months of daily use, and the total change in curve increased to 12.5 degrees, which represented a 19.7% improvement in this group with associated increases in length. So traction is probably a dose-dependent phenomenon, and the more a patient can put into it, the more they'll get out of it. This device seems relatively well tolerated, and we'll see if there's any additional second-generation traction devices that enter the market. The last thing that I want to talk about is combination therapy, and that really should pull together everything that we've discussed to this point. The goals of combination therapy is to pull from the synergistic effects of the various therapies. So perhaps we can achieve something that on the whole is greater than the sum of its parts. This is certainly more labor intense for the patient and does require a highly motivated patient in order to successfully implement this technique. And if we do have success, it is difficult to determine from where this effect is derived. So we have to be okay with that before we even start. Support for combination therapy in general does come from a study, which I highlighted early in the talk, of 39 patients who had L-arginine, pentoxifylline, traction, and intralesional verapamil. And responders in this study had a curve reduction of 26.9 degrees. When you remove the traction, it was 20.9 degrees. So I don't believe that this suggests that this is the optimal combination regimen, but I think it supports the utility of combination regimens in general. However, there has been a study of the 2 most efficacious agents that I presented today. This compared Xiaflex alone, Xiaflex with first-generation traction, and Xiaflex with second-generation traction. And what they found was by adding these different therapies, these more efficacious therapies, you had a greater reduction in curve. So Xiaflex alone had 16.5 degrees. Xiaflex with a first-generation traction device had an improvement of 20 degrees, and Xiaflex with a second-generation traction device had an improvement of 30 degrees. And these are all statistically significant differences. So what do I do, right? I do utilize the previous one, but I add daily tadalafil. I think the benefit of the daily tadalafil is to give these patients ownership of their own treatment. I think the scientific data behind it supports its use, and we know it's safe for the use of treating ED in PD patients anyway. I give my Xiaflex via the new protocol that I described. I give it on back-to-back days always. I always inject to induce an erection the first time I see it and favor the point of maximal curvature over the bulk of the plaque. I do utilize aggressive modeling, and I have steadily been increasing the force that I apply to the penis over time. I also recommend a second-generation traction device. I tell them 30 to 60 minutes a day is enough, and that's partially because the manufacturer of Xiaflex does not officially recommend the use of a traction device as part of the CCH protocol. It was not included in the IMPRESS trials, but I think the support coming from the trial that I just highlighted suggests that it is both safe and potentially offers an additional benefit. So in short, don't use radiation, don't use shockwave. I don't think vacuum therapy makes sense, but you can use traction therapy as either a monotherapy or as part of a combination regimen. And if you're looking for the greatest reduction in curvature among non-surgical options, this will probably be achieved with combination therapy. So where does this bring us? I think the point is that there is limited data to suggest that any non-surgical approach is efficacious, and it depends on your definition of success. You can reduce curve via monotherapy with CCH and traction, but surgical therapy does remain the gold standard. Combination therapy provides us the best chance to achieve the optimal outcome, again, if the optimal outcome is maximal reduction in curve. And patient counseling is key here with clear goals of treatment. Surgery will likely result in a straight penis, and non-surgical therapy seldom does. So if you have a patient who needs to be 0 degrees in order to be happy, I would likely direct them towards surgery either in the short or long term. That is separate from the discussion of potential surgical downgrading, but ultimately a patient who needs to be perfectly straight is probably going to need surgery. I'd like to take some time for some questions. Hopefully this stimulated some discussion. Again, thank you for the platform to give this talk, and hope that this helps in your clinical practice. Thank you.
All right, Peter, nice presentation, nice talk. It's refreshing to see somebody who actually induces an erection on each cycle of Xiaflex, because many of us do not or have not, but that's something I've been doing since the medication came out, and I think it's powerful for documentation as well as for engagement of the patient. But my question for you is about oral treatment. Now, we all know that the guidelines say that no oral treatment is recommended, but I know personally that many of the people on that panel, particularly all the urologists, do use oral medication as a placeholder. Now, I was wondering what you think or how you feel about oral medications personally in your practice. Do you prescribe them, and if so, what and how much and for how long?
So I do everything with a shared decision-making approach, but I would say the vast majority of my Peyronie's patients walk out with a prescription for 5 milligram daily Cialis. And I say, if we're going to do it, let's set a deadline, and I use the active phase. So in somebody with a stable phase disease, it's as part of a combination regimen. As soon as we're done with everything else, we're done with the oral therapies. But for my active phase patients who want to maybe hold off on something more invasive, but want to feel like they're taking ownership of their own disease process, I think that the Cialis serves a role there. I think there's also a degree of, or a number of patients whose bother is impacted by their sexual performance. And if you treat that underlying ED and they can participate in sexual activity the way that they want to, they get the sensation that they are doing something positive for their disease process. So active phase until the active phase is over, stable phase until we finish whatever treatment protocol we agree upon.
I have another question if nobody has one. And this one is particularly on modeling, your aggressive modeling. Have you ever modeled someone so much that you've caused a penile fracture?
No, I haven't yet. Okay. I've heard, you can hear So the difference to me is I hear these like kind of knuckle cracking sounds when I'm modeling aggressively. And when those guys come in the next day, they don't have an eggplant deformity. From talking to other providers who are doing this, the fracture sound is very distinct and quite loud. So I think you can have a pretty good idea of if you actually fractured somebody or not. And to me, that's the slow incorporation of this aggressive modeling to the level of your comfort.
I see. And when you do the aggressive modeling, do you bring them back? I know you inject on consecutive days. Do you bring them back on a third day or fourth day to evaluate them, or just have them call in? How do you manage that?
So I model them on both of the back-to-back days. I model them in the erect state, which is not as aggressive, and then on that second one, pretty aggressive modeling the flaccid state. And then I just utilize like our patient portal or phone calls to ensure that everything went okay after that. I don't force them to come back in for a visual evaluation. I find Peyronie's patients to be very reliable with regard to their own genitals. So if they don't think they're fractured, they're not.
Okay. All right. Yeah, we know that Landon Trost, he actively, aggressively models on an erect penis, and he intentionally tries to cause a fracture. Then he has those patients come in several days in a row where he actually rewraps them and checks them every day.
Right.
So I think from a medical legal standpoint, he kind of gets out of that issue by doing that. But the rest of us who, I don't do aggressive modeling in the erect state, but the rest of us who do may have a lawyer call us at some point if the patients are upset if we've intentionally fractured a penis.
Yeah, I agree. I think what he's doing is it's impressive. I think it's efficacious. I don't think I have the bandwidth to incorporate it into my practice. So by seeing them within 24 hours of modeling on the erect penis and then rewrapping myself in the flaccid state, that's kind of the mid ground that I'm comfortable with at this point.
Okay. Thanks.
Sorry, Dr. Bennett, I have a quick question. When you're working with residents or trainees or providers who maybe don't have as much experience with aggressive modeling, are there any, you talked about kind of some of the tactile feel or sounds that you hear. Is there anything else that you kind of point to when you're educating people on how to incorporate and get more comfortable with more aggressive modeling?
Yeah, it's hard. It's a feel thing, much like, learning how to do a vasectomy. So I think a lot of tension on the glands is key. And then I use my dominant thumb to kind of run up and down where that curve is. And you'll feel that point of resistance where you can tell yourself, all right, maybe this is the area I don't want to push through. So try and see where the plaque is going to give a little bit and never any sudden movements. So always, you can be strong, but always smooth. These bird-like movements, I think, are probably the ones that are going to be associated with problems. And thank you, everybody, for using this hour to spend it here. Really do hope it helps, and it is an honor to be given the platform.
I want to thank Dr. Tsambarlis for giving the time to write this presentation and to give it to all of us. Of course, it's recorded and it will be found on our website. Remember, this is a CME module, so by listening to this, you will get approximately an hour of CME credit. If you have any additional questions for Dr. Tsambarlis, please note his email address on the slide in front of you, and also he can be found in the portal. Thank you all for attending, and we hope that you'll make time for this event in the coming months.